Good evening, everyone. It's so nice to see you all, and thank you so much for joining our weekly community discussion. And thank you to all who are on our live stream and our Zoom as well. My name is Shekar Krishnan, and I'm running for City Council here in Elmhurst and Jackson Heights. And one of the most critical issues that is facing our city today is our healthcare system. And I mean that first in two fundamental respects. First, we absolutely need universal healthcare in New York State and New York City. It is long overdue. And if anything COVID has shown us, it is that this crisis is urgent. Second, our public hospitals have been the most critical point of access for healthcare for our most vulnerable, our uninsured, our undocumented, turning away no one who needs services in times of need. Yet one of the things that shocked me, and I learned very openly through COVID, was the way in which our public hospitals receive far less in public dollars than every single private healthcare institution in our city. That includes public safety net hospitals like Elmhurst Hospital, which was the epicenter of the COVID-19 outbreak in our city. And that is absolutely shocking and unacceptable. There's so much more that we need to do to really invest in public hospitals like Elmhurst in our city and make sure that these hospitals and the workers in them who are on the front lines of our healthcare system, of any pandemic or healthcare crisis in our city, receive the resources, attention, and services that they desperately need to serve those in our community who have the least access to healthcare. If we are to come out of this pandemic and really have a reformed and radically changed healthcare system that is actually working for immigrant communities like ours, then the fight begins and ends with our public safety net hospitals like Elmhurst Hospital. And I'm so excited and happy tonight to have with me two very distinguished panelists who are doing such incredible work in our city around our healthcare system, around our public hospitals, and are also community residents right here in our neighborhood too. We have with us Chanel Martinez, who is a community health advocate and educator, and also a community resident here too, advocating every day for public health equity and public hospital equity in our city and right here in our community and right here at Elmhurst Hospital. We also have with us Dr. Sheela Maru, who is a physician at Elmhurst Hospital and also Mount Sinai Hospital, and who can both tell us from their experience during this pandemic and after and before as well, how much these issues of public health justice matter so much to neighborhood residents like ours. And Dr. Marutu is also a community resident here as well in Jackson Heights. So without further ado, I thought we could start with some basic questions so we can explore a bit more about our healthcare system and our public hospitals, and then go into further detail from there about the inequities that we've just been talking about. So Sheela, maybe we'll start with you. Tell us a little bit about what do our public hospitals do in New York City? What is the role of a public hospital like Elmhurst, and what does it mean to be a safety net hospital?
Thanks, Shekar, and thanks for having me. Nice to be here this evening. And I just want to start by saying that, one, I'm excited to be here and talk about this really important issue with all of you. And two, I am speaking just on behalf of myself and not the institutions that I'm part of. I'm definitely proud to be a physician and member of the Elmhurst Hospital community, but I'm not speaking on their behalf. And similarly, I do some research with Mount Sinai Hospital, and again, not speaking on their behalf. So to answer your question, Shekar, Elmhurst as part of the public hospital system is one of the 11 acute care hospitals. And then in addition to that, there are numerous clinics and other outreach programs that the public hospital system has. In Queens, we have both Queens Hospital and Elmhurst as the two big acute care centers. And really, the public hospital system is our safety net. We treat all New Yorkers, regardless of their immigration status, regardless of their insurance status. We turn nobody away. This hospital system treats approximately a little bit more than 1 million New Yorkers. And we are the largest hospital system for Medicaid patients with behavioral health needs, and also for the uninsured in the city. And many of you may know about the Nyc Care Program, which is a more recent program, and that is to improve primary care access for those without documentation status or without health insurance.
Thanks so much, Sheela. And Chanel, can you tell us a bit about, well, two questions. One is, maybe a bit more detail about NYC Care and how it works. And then also, given the explanation that Sheila was just given about, our public hospitals, what is the difference between public hospitals and private hospitals? And what does it mean to have really two different tiers of healthcare in our city? But maybe we can start with NYC Care first.
Yeah, so New York City Care is actually a really cool program that the city released about a year or so ago, where the idea behind it is it's not health insurance, but it's a form of healthcare coverage. It's a healthcare program that's aiming to enroll people into a care plan at Elmhurst Hospital or hospitals across the city, the public hospital systems. It's for people who are either finding insurance through the New York State of Health unaffordable, meaning that it's more than 8% of their income. The premium would be more than 8% of their income, or that they're actually not eligible for insurance. In New York, we actually have something called emergency Medicaid. And so it's a type of Medicaid that you can get in emergency situations, regardless of your immigration status. And so if you are only eligible for emergency Medicaid, you can enroll into New York City Care, which it sort of treats you as if you did have health insurance coverage. It provides you with like a sliding scale fee for the services that you would receive at the hospital. It gives you a membership card with a phone number with 24/7 access to this hotline that you can call and schedule a doctor's appointment. They're promising a doctor's appointment with a primary care physician within 2 weeks of signing up. So it's a really great program that's really advertising the services, both primary and specialized, that the New York City Health and Hospitals have to offer. So that answers your question about New York City Care. But in terms of the differences between our public and private hospitals, one, we have, the ability to access the private hospitals depending on your insurance status. So depending on your insurance status and also the type of insurance you have, you can access certain private hospitals. Just because you have private insurance doesn't mean that you can access all the services at all the private hospitals. But I think that the main takeaway here is that there is a difference in the way that patients receive treatment at public and private hospitals. Patients at public hospitals don't have as many resources and services at their availability. The public hospital system is stretched so thin that patients often have to wait longer to see providers, and just the quality of care that they're receiving, while it's still, we're New York City, it's top level care, but they don't necessarily have the latest technologies. So there is a difference in the type of care that's being rendered at the public versus private hospital systems.
Mm-hmm. And Sheila, can you tell us a bit about when Chanel was mentioning the difference in care in terms of resources? What does that mean in terms of funding itself? And I was kind of alluding to this before too, but can you give us a better sense of how public versus private hospitals are funded, and also what are the disparities in terms of financial resources?
Sure. Yeah. Just one comment too about what Chanel was mentioning. I guess I do want to say that like kind of thinking about and remembering all of the colleagues that we have in the public hospital system, I do feel that the healthcare workers in the public system really kind of go the extra mile to do their best to provide excellent care. And I would vouch for that care and receive care there myself. But I think that, as you said, Shekar, there are some real disparities in terms of the support, public support, and that does affect the resources that those excellent clinicians and providers have at their fingertips to be able to provide the care. So I guess I would describe the care in New York City more as segregated than anything else, and segregated by insurance status, which I think in today's world doesn't make sense and kind of leads to increasing disparities rather than solving for reducing them. So in terms of the funding, I think one important thing to understand is that private hospitals can turn away people. They don't have to see people on Medicaid. They don't have to see people who are undocumented outside of the emergency room. And for that reason, many patients kind of get shunted into the public hospital system. And Medicaid reimburses at a lower rate than most private insurance companies for most things. And so that leads to, like right there, a disparity in terms of what reimbursements that hospitals are able to get or recover from the services that they're providing. So on top of that, there is something called the disproportionate share health money that's coming from the federal government, and that money is being distributed for the purpose of this lower compensation that hospitals are recuperating from Medicaid. And so that is going to hospitals that are taking care of Medicaid patients, which are nonprofits, and also the public hospital system. And that money should be kind of distributed fairly based on the number of patients that are being cared for. However, there is kind of disparity in terms of the risk that the public hospital system takes in terms of any funding cuts to that federal money. So with the ACA, that money is at risk of being cut, and the public hospital system would be the one to bear the brunt of that budget cut, even though they're serving the most Medicaid and uninsured population. So for that reason, I think it's an important kind of point for advocacy to say that first, in terms of federal funding, to prevent federal funding cuts for disproportionate care. And secondly, to protect specifically safety net hospitals and hospitals that are doing most of the work for those who are uninsured and who are on Medicaid, because they're not able to recuperate the resources that they need to spend to give high quality care. I think the other thing to think about is really reimbursements for Medicaid. And this kind of brings us back to that point that you made earlier, Shekar, about universal healthcare, and the importance of having healthcare access for everyone and making sure that compensation for services is kind of even across our population. And that would really kind of help with this whole disparity that's generated because Medicaid can't reimburse at the same rate as private insurance companies. I hope that answers some of the questions.
Yes. Absolutely, that's very helpful, and also just puts out a lot of information out there that is so important to know too about, for example, Medicaid reimbursements and how they work, and also the disparities in resources. And I want to get back to that in a bit as well. But I did want to hit on one point you made, Sheila, which I thought was so critical, and was actually my next question too. Is about our healthcare workers at public hospitals, who are our extraordinary heroes, frankly, on the front lines of this work, because not only are they serving the most vulnerable populations who are uninsured or undocumented, or our at least access to care, but they're doing so with far less resources than many other private institutions do that actually turn away so many patients that public hospitals don't at all. So in terms of our healthcare workers and the work that they're doing, plus the constraints they're operating under, it is extraordinary how much, even during a pandemic, our frontline workers at hospitals like Elmhurst were doing. And that leads me to my question about, it's two levels. One, the lack of resources obviously affects the ability to provide resources to provide services for patients at hospitals too, but it also affects the resources given to some of our most heroic frontline workers that don't always have the resources they need or the PPE they need to do their work. And so from your perspective, I remember you and I had conversations about this during the pandemic itself, when you were at Elmhurst too. What did you notice in terms of, at a very fundamental level, the disparities in terms of resources given to healthcare workers in the public setting versus healthcare workers in the private setting? And how did that affect the treatment during the pandemic itself, in terms of what resources you had to call to, or what stress or constraints you all were placed under?
Yeah, that's an important question. Definitely, I agree with you that the COVID pandemic kind of really laid bare some of the consequences of these disparities in resources. And I think for multiple factors or multiple reasons, we really became like you said, the epicenter of the epicenter in New York City, really like our neighborhood, and specifically Elmhurst Hospital and the communities that we serve. And I could feel this when we were going through it, but learned the numbers later, that I am kind of have a little bit of insight into both Mount Sinai Hospital, which also cared for a huge number of COVID patients, and Elmhurst Hospital, and learned later that we cared for more COVID positive patients, and we had far fewer beds, far fewer staffing, and far fewer resources. And to kind of think about that, this really mega giant high resourced hospital center on the Upper East Side versus Elmhurst, and the fact that we actually cared for more patients who had COVID during the surge pandemic was just kind of mind-boggling, like why we weren't. And I think it kind of speaks to, again, one, universal healthcare, but two, really the coordination and kind of linkages between our kind of fractured healthcare system. That at the time, the idea of being able to kind of share resources and transfer patients appropriately to kind of spread things across in a more fair way didn't really happen. Yeah.
Yeah, I think, that's you hit such a critical point in terms of staffing ratios, in terms of, beds and beds. And I think that's where all of these things started to come. COVID obviously didn't create this. It exacerbated and revealed it for everyone to see, just this level of inequity, not just in healthcare, but also in many other areas too, in housing and otherwise. But I, do remember hearing from you about it at the time as well, and also just seeing so many reports about these disparities in the resources that were there, that really were shocking, given how many, for example, as you mentioned, patients staff at Elmhurst were treating on a daily basis compared to other hospitals too. And Chanel, on that point, I wanted to ask you about, one of the things that we've talked about too is when it comes to protecting and giving resources for our frontline workers. It's also our, community health advocates and navigators at the hospitals. It's our social workers. It's our janitors. It's our home health workers. And so I wanted to just, touch a bit about that too, about how these disparities in resources affect so many across the field of healthcare in public hospitals, and what that means too, and the implications of that for hospitals as well.
Yeah, I want to just say that as somebody who's helped people access healthcare outside of New York City as well, whether it's Long Island, New Jersey, or Florida, our H&H system, our health and hospital system, is absolutely incredible. The fact that you can seek care regardless of your insurance status or immigration status here in New York City at a health and hospital location is really quite extraordinary. It's not something that you can do in other states, in other cities. So the fact that we have this safety net and everyone can seek care is really quite incredible. And our health and hospital systems, because they are so accommodating, they can actually be really welcoming spaces for people who are undocumented, people without health insurance status. So I always recommend that people who have concerns about accessing healthcare because of their status, they seek care at a health and hospital site, because they're never going to feel unwelcome. They're never going to be made to feel like they don't belong there, and they'll always receive the quality of care that they deserve. I think that across the board, whether it's a public or private hospital, we aren't investing enough in social workers. We're not investing enough in healthcare navigators, in community healthcare workers, and home health aides. Getting your insurance carrier to cover a home health aide is super difficult. I can speak to, my personal experience as somebody with my family member with dementia. He isn't able to access a home healthcare worker, which he so desperately needs, despite having insurance. And just having these sort of nuanced criteria that insurance companies set in order to access these really specialized workers is really frustrating, because they're essential to accessing quality care. But I think that we need more social workers in hospitals, because we need more access to mental health care. We need more benefits enrollers, because I think that anytime somebody steps into a hospital, you should be screened for SNAP, you should be screened for health insurance, you should be screened for, WIC, all of these resources that the city has to offer. I think that you shouldn't leave without being screened for them. I think that we need healthcare navigators, because so many people will get a statement, not understanding that it's a statement and not a bill. We have just so many questions when you walk into a doctor's office that need to be addressed, whether it's about financial, whether it's about your treatment, whether it's about, accessing an interpreter. I think that we need more people in the healthcare system that are going to empower patients, and that's true across the board.
It's a really important point that I think you made, Chanel, which to me stands out a lot too. The way in which all of these systems are connected, right? Like if you're coming to a hospital with health issues and you're undocumented, let's say, that also ties directly to benefits you need to get, not just health benefits, but also SNAP or to housing. And I know, Sheela, you and I during the pandemic had talked about this too, the way in which so many patients who are coming to Elmhurst Hospital too, for example, or the most vulnerable communities when it came to COVID, were those living in who couldn't socially isolate, living in overcrowded housing because of how unaffordable housing is in our city and how that's disproportionately affected low-income communities of color too. So all of these systems, I think, are tied together. And I think, Sheela, your point is so right that, the critical importance of having social workers as part of our hospital system is as true in the hospital system as it is in the school system, as it is in, the housing system. For us as housing advocates and housing lawyers too, we always talk about the critical importance of having social workers to help so many of our tenants apply for benefits they need, which, if you're facing eviction, there's probably a whole host of them that you can qualify for many different reasons. And I just think that, that's such an important point to underscore, as is the fact that, health and hospitals are really, and that's why it was so shocking to me, really our most fundamental line of defense for so many in our city, safety net hospitals. Yet the disparity in resources is just so egregious. And, it's precisely because they're safety net hospitals that they should be receiving far more, and to help workers so much more too. Sheela, I wanted to jump back to you for a second too. A point that we've talked a bit about that Chanel also touched on too, was home health workers, and how often their vital work is unseen in our healthcare system and not supported in the way that it should be, given the difficulties of the jobs that they undertake too. What are some of the things that New York City could do to better support home healthcare workers and to ensure they have the resources they need?
Yeah, I think that it's such an important cadre of workers, and definitely agree with what Chanel was saying, the importance of social workers and also home health workers and the kind of critical needs that they fill. And I think just one comment to remember is that they are a huge workforce in New York City. And like you said, Shekar, they're kind of hidden or not really recognized, but there are like 130,000 home health workers in New York City. And on top of that, more than 5,000 community health workers and doulas. And so together as a workforce, there are more home health workers than there are nurses, than there are teachers. And so it's important, I think, to remember that, that they're filling this like critical need across so many homes and families across the city, and yet they don't have recognition. So I think, definitely recently I've really seen that there are huge gaps in ability to get vaccinated for these really critical frontline workers, because they're not linked to a big institution often. Often they are they don't have that kind of connection into someone who's getting a direct vaccine supply. So that's, I think, one of the issues and one of the barriers. And I think that was similar earlier in the pandemic with testing, in terms of access to testing and PPE. So I think, all of these things link back to, again, kind of recognition of them as a workforce and thinking about kind of the protections that all workers in such jobs should have, which is full-time compensation, benefits, and by recognition, also recognition of the needs and being able to have a clear supply chain for all of those needs being met.
Mm-hmm. That's very helpful to hear. And I think, a couple points I wanted to make. One, just for everyone to know too, that we are actually going to be releasing, hopefully by tomorrow, later this week, our public health platform as well, which you can see on our website, www.voteshekar.com, where many of these issues that we're talking about today are being addressed to, and where individuals like Sheela and Chanel both had a lot of input too, in thinking through these issues and these policy changes we need. In particular, also highlighting the importance of supporting our home health care workers in the way that Sheela mentioned as well. So please stay tuned and check that out too. And the other point I wanted to mention, Sheela, as well, is a couple thoughts came to my mind that I think you both can speak to. But, and before doing that, I was just going to also point out, we have a couple questions left, and then we want to start getting some questions from the audience. I see some questions being sent to me already that people have as well. So if you do have other questions too, please put them in the chat or message them to me. If you're on Facebook Live, please send them along too, and we can start asking questions. So in a few minutes, we'll transition over to questions. But one thing I want to talk to you both about too, is testing and the vaccine. So maybe we'll start with testing first, Sheela, because you mentioned that point. We went all over the map with testing in our city. Places where you would hear would be quick to get a test, other places where you're waiting online for hours. results would take days to come in. By the time the results came in, it kind of defeated the purpose of getting a test in the first place. What is the status of testing right now in our city, and how could it be done differently to make sure it's reaching as many people as possible?
Yeah, I mean, I think you're right. It's like remembering all the ups and downs and the kind of where we've been with testing in this journey is pretty remarkable. I mean, I think that, you know, having as easy access to testing as possible for anyone who thinks that they possibly could have a contact is kind of the gold standard, or like the ultimate goal of testing. And to make it accessible, it needs to be, especially in communities like ours, it needs to be accessible in multiple different types of locations, ideally, you know, linked with places that people are comfortable with and trust. And so I think engaging with community-based organizations or other cadres of health workers being outside of the hospital setting or hospital system, I think all of those are very important. And I think the Department of Health has made a lot of moves towards kind of trying to do that, trying to engage with different types of providers and community organizations to be able to provide more access to testing. Although mobile testing units is something that's popped up more recently. And I think all of those efforts have been really helpful to increase access. There were definitely times at which supply was just short also. And I think that's another important thing that has been worked on over time, is kind of ensuring an adequate supply of all of the materials that are required for testing. And I think one thing to also mention is that I do think that there's an important link in terms of how we think about testing and how we think about vaccination. And I think it will be, you know, very much the same kind of channels of trusted partners that we need to work with to make sure that vaccine distribution is equitable and reaching those who, well, reaching everyone. And by everyone, it really should include all of those who had a harder time having access to testing earlier on, or who often have a harder time accessing the healthcare system, period.
Mm-hmm.
I'm sure Sheela has a lot to say about this too, though.
Yep, exactly. I was going to say, I think that one thing I want to make a point on is that the importance of partnering with community organizations and how that's a trusted way of vaccine, of testing access that I don't think the city has done enough of a job of really instituting. And Chanel, I wanted to, you've done so much work on helping so many people apply for vaccines or vaccine appointments prior to that testing as well. And you've seen so much the ways in which the system is so complex and complicated for so many who are trying to make an appointment. So before, I have a few questions for you on the vaccine approach that kind of mirrors testing, but just as a basic point, can you give us an update on how the vaccine appointment, the process is going right now, and what generally the different ways that people can apply for a vaccine, what's working, what's not working?
I will say that as of yesterday, we're feeling much more optimistic about vaccines. So many new appointments were released last night and have been continued to been released throughout the day. But I think there's been a huge supply issue, which is, you know, not really here in New York, but the federal government allotment of vaccines throughout the country. But I think that as we're seeing, you know, over like half the adults in New York City or New York State are eligible for the vaccine right now, which is so many people eligible for not enough vaccine. More eligible people are there are more people who are eligible for vaccines than there are vaccines, and so this is where we're seeing a lot of the slowdown in people getting access to appointments. But I think that like we've been saying here, partnering with community-based organizations that have been on the ground throughout the entire pandemic, checking in on their community members, you know, helping them access food resources, insurance resources, PPE, whether it's masks or hand sanitizer that were once a very hot commodity at the beginning of the pandemic. These are the organizations that have built a relationship, not just throughout the pandemic, but for years now with the more marginalized communities in our city. And I think that there's a lot of distrust in the government around the vaccine, about whether or not it was developed safely, about, you know, who's going to be receiving it. Are we really just lab rats? And, you know, these are the conversations that I'm having with my family members. I think that our, you know, community-based organizations are having with their communities. and are able to debunk some of these myths and some of these misconceptions and some of these fears and some of these hesitancies because of that established relationship. And so I'm glad to see that our city and our federal government is recognizing the importance of CBOs, and also, you know, community-based organizations like churches, synagogues, temples, and working with these to create pop-up clinics. But I do think that we need much more access to vaccines. And I think that's, there's been a really big emphasis on electronic appointment making. These portals are really hard to access for those with technology, but it's completely leaving out those without access to technology. And this includes, you know, access to internet as well as access to a phone or computer to log on and make an appointment. Also excludes people who don't have an email address. And so I think that the city is taking steps to improve these appointment making portals, but they do remain insufficient. And I think that we really need to work on making sure that our immigrant communities, our limited English proficient communities, and the communities that have been historically marginalized and historically mistreated by medical systems, by empowering them and making sure that, you know, they are being prioritized in this vaccine distribution.
That's a really important point that you made too about you know, the way in which I feel like vaccine distribution and rollout should mirror really what testing distribution rollout should be too, right? Like relying on these trusted networks, community partners, and making sure it's as widely accessible as possible. Just taking a step back for a second too, because I saw one question that was sent to me about this as well. What are the if you are eligible for the vaccine right now, what is the simplest or best way to apply for? Like you mentioned, it's all electronic now, which has got its huge limitations too. But what are the best ways if you want to apply for a vaccine to check what appointment slots are available to?
Yeah, so vaccinefinder.nyc.gov is a New York City run website, and it's going to, you put in your zip code or your address, and it's going to populate the vaccine locations that are closest to you. And they'll tell you whether or not a vaccine is available and what type of vaccine, whether or not this is for people who are over 65 or only, since the pharmacies are locations that are only prioritizing people who are 65. And so I really recommend that people check out that website, and that website will actually direct you to the websites of the locations that you can book on. So those are websites like, you know, the Health and Hospitals website, it's the Vax for NYC, which is the Department of Health hubs, and then it's also the private organizations like affiliated physicians, the private hospitals, things like that. And so I can drop them in the link in the chat. But there's also a phone number. So if people do have concerns about accessing this information online, or don't feel like they have the capacity to do so, they can definitely call a number as well to book an appointment.
That would be great if you're able to put that information in the chat too. And so it sounds like vaccinefinder.nyc.gov is the best place. And it sounds like there's also like a 3 different categories of where vaccine distribution is, right? Like one is through health and hospitals, one is through these DOH hubs, like the one in Sunnyside at Aviation High School, and a third way are through private institutions or private healthcare institutions that have them too. One point you mentioned as part of that was language access. And in addition to really the way in which you have to have access to technology, it sounds like, well, let me ask you this. How has language access been when it comes to applying for the vaccines and making appointments? And how has that either complicated or simplified the process?
I think that initially one of the New York City websites wasn't available in other languages. It's, you know, since been updated, but I think that it's really crucial that these websites are being translated in real time and are, you know, the translations are accurate. But I think that if you have to wait online and, when you're calling in for an interpreter or somebody who speaks another language besides English, we're not being equitable. There shouldn't be a longer wait for those who speak another language than those who speak English. And so I think that we really need to increase our efforts in order to make sure that people are gaining appointments regardless of their ability to speak English. I do also want to plug a few websites that are volunteer run that are helping people find appointments. New York City Vaccine List is a volunteer run website that's providing real-time updates on available appointments throughout the city. And then TurboVax, which has been widely in the news lately, is also another website that's actually run by a code that's automatically populating instantly when appointments become available. So I can put those websites as well into the chat, but those have been helping a lot of people book appointments because it can be really difficult to have to click on multiple websites in order to find an appointment.
So Turbo Vax and Vaccine List aggregate from all these different categories that we've mentioned of a place where you can get the vaccine and tell you where there's availability?
Not all of them, but a lot of them.
Got it. Okay. That's helpful to know. And I agree with you. The point about language access, it applies as much to vaccine distribution as it does to our hospital system too, right? Making sure that we're increasing language access and accessible care and interpretation services in hospitals too. I'm going to also, I see some of the questions here too, so I want to make sure to get to them as well. Sheela, one question for you that comes from our audience too is, what does a broad public health system look like to you? And how does it tie into community-based healthcare? So what do we think about when we talk about systemic changes to healthcare, and what does that mean in terms of community-based healthcare?
Yeah, that's a great question. I think that kind of what Chanel was speaking to earlier in terms of having a stronger linkage between this massive home health force and the actual healthcare delivery system, which is kind of very centered on hospitals and on clinic-based care. Whereas I think if you talk to most people, what they want is care that's in their language from people who know their community and understand their culture and close to home. And so really, you know, home-based healthcare meets those checkboxes and oftentimes is really not closely linked enough to the formal healthcare system. And as we talked about earlier, there are also a lot of gaps in terms of kind of recognition and kind of meeting the resources that those healthcare workers, extension healthcare workers or home health workers need to be able to provide adequate care. But I think with really strong linkages between the two systems, that's what I see as being a much stronger, broader kind of health, community care health systems approach.
Mm-hmm. That's very helpful to hear. Another question, Chanel, that we have too is, well, this is actually for both of you. If each of you could choose to increase public hospital budgets in one area, what would it be? Maybe Chanel, you want to go first, and then Sheela?
That's a tough question. I think I'm a bit biased. I think that, you know, the patient navigator, the benefits enrollers, the social workers need a lot of funds because I think that they really get to, you know, I think that as somebody who works in public health, you know, we need the public health, the social service navigation in tandem with the medical assistance. If somebody doesn't have running water, doesn't have enough food, doesn't have a stove, doesn't have a roof over their head, they're not going to get better, you know, regardless of the medication that they're being administered. These are really vital aspects of somebody's healthcare accessibility. And so I think that if we invest more in social workers, patient navigators, benefits enrollers, you know, and generally also just resources across the city, right? And so I think that, you know, for you, Shekar, housing is such a big issue. As somebody who helps people access housing resources, the only so many resources are dedicated to eviction prevention or eviction assistance, but we need to stop people from getting to that point. We need affordable housing. We need, you know, assistance with rent, and I think that we need to invest in these resources that are going to prevent people from entering moments of crisis. And I think that our social workers, our benefit enrollers, and our patient navigators are the people to do that.
That's a great.
Sorry, I just also dropped in the chat the Queens only locations to book appointments. So that's City Field and York College. York College is only for certain zip codes right now, but next week it will be for all of Queens.
And Chanel, for those sites, you can just directly apply. Like those are the sites where you can check the appointment availabilities at those specific locations and apply directly there if it's open.
Yes.
Mm-hmm. And one, you know, thing I want to mention. I'm so glad you said this too about it's not it's preventative, but it's different from eviction prevention, for example. Is the services you're talking about, and just like in the housing context, are ways to stop this slide to the point where it becomes so dire. And we say this in the housing context too, where, you know, one of the biggest problems that I have with the right to counsel program in New York City for tenants is that it's an eviction defense, eviction prevention program, which means you're not even getting an attorney until you get served papers and when you go to court, and that's when you get your attorney. And there are so many tenants who are so freaked out and who need help long before that point, that when it gets to court, it's so late in the process of harassment, and you're on the verge of losing your home. It shouldn't be that that's when the resources kick in to actually help you at that point, because so much damage has already been done. And I think the point that you make too about our healthcare system, when you talked about benefit specialists and you talk about healthcare navigators and social workers, is the way in which you stop really the dam or the floodgates from opening in the first place, and address healthcare at a much earlier line of defense too. So I really do appreciate that, Ty. Sheela, what would you say if you had to choose one area? What would that area be?
Yeah, I mean, I guess very much in line with what you were saying, Shekar. As a doctor, I feel like I'm often seeing patients in very critical moments when they've already fallen ill. And many times, if you really take a broad view of things, that illness can be linked back to a variety of different social ills, right? A variety of different social determinants of health. And so I'm going to just say, I agree with Chanel. I really think that figuring out ways to support people in all of the variety of different social determinants of health is really ultimately what's going to make a difference. And I do think the front line for that group of ailments are our social workers and our health navigators and our home health workers.
Mm-hmm. That is such a, I think, such a critical point that COVID really exposed everyone to see the social determinants of health, right? And how these systems are so interconnected. And you know, the need for not reactionary approaches to healthcare, but really addressing those underlying determinants, as you mentioned, I think are so critical. And another question that we have as well is, are there, this goes really both of you, are there any pieces of legislation in New York State at the moment that we can support to help with some of the issues that you've raised?
Shekar, we should probably bounce this back to you too.
Sure, I can think of one already, but if you have other, well, I'll go first. If other ideas, you can tell me too. But I absolutely think the New York Health Act is critical, and you know, it's the most fundamental way to really transform our system. And it's really shocking to me that you know, there hasn't been that we haven't gotten there yet too, and especially after this pandemic. So I feel like that's such an important piece of it too. And I think, you know, legislation that I know, you know, organizations like NYC, New York State Nurses Association, have been really advocating for, to, you know, better address staffing ratios when it comes to hospitals, and particularly, you know, nurses and other healthcare workers, and making sure that they're appropriate and adequate is such a critical piece of the work too. So those are two that I think come to my mind too. I don't know if either of you have others as well.
I mean, I completely agree. I think we need to pass the New York Health Act. I think also a piece of legislation doesn't have to be directly related to health in order to impact the health of people. So, you know, I'm thinking about like when New York State passed the ability for everyone, regardless of immigration status, to receive driver's license. That's a public health initiative. When people are driving safely, that's increased public health care. I think that when there was another one that I was thinking of, but it's lost my mind now. But I think that any piece of legislation that provides protections to people, whether it's in transportation, whether it's in, you know, financial resources, public banking was the one that I was thinking of. But the establishment of public banks, that helps people receive financial resources. And at the end of the day, your social economic standing directly correlates to your healthcare or your healthcare outcomes. And so I think that these broader issues can really assist our goals and improve public health care.
Mm-hmm. I think, Shiv, I don't know if you want to add anything, or if that covered where.
Yeah, I agree. New York Health Act is number one priority. I also guess I just wanted to say too that now with you know, federal stimulus money being distributed across the states, I think another kind of important thing to advocate for is really that we get our fair share from those extra monies, and that once we have that fair share, those monies are distributed within the state in an equitable way. And so is the public hospital system or other systems that are taking care of really, you know, are most vulnerable, the uninsured and populations that are being most affected by COVID, be on the receiving end of those funds.
Absolutely. And there are two other points that came to my mind too that are worth mentioning. I think one is a moratorium or, complete prohibition on closing public hospitals in New York City. It's surprising that we have to really identify that as an issue, but given, the way in which the city doesn't do enough to invest in our public hospitals, we have to oppose whatsoever any closures of public hospitals. And in fact, actually fight, obviously for so much more in the way of resources too. And that sense, the budget is really a reflection of our values, right? Where we decide to fund and what we decide to fund reflects so much about what services we value as our city. And so, of course, one of the conversations that obviously one of the main threads of our conversation tonight is about massively investing more in and increasing funding for our public hospitals. And so one question I saw from the audience as well is, will increasing funding for public hospitals require raising our taxes, or are there other opportunities and means to generate resources for public hospitals? What do you both think?
I mean, I think one issue related to the financing for distribution for public hospitals or for the hospital systems also comes to tax dollars that we're not getting because so many of our private hospitals are nonprofit institutions. And so they're getting massive tax breaks. And at the same time, they really behave like private institutions in specific sense that they have very high executive pay and they have massive tax breaks, and they are kind of essentially turning a profit in the sense of the way that they are using the funds that they're able to recuperate. So I think that's just something to think about, like pay caps for executives of nonprofits and kind of reconsidering the tax breaks that we're giving these massive private institutions that in the way that they're expanding and in many of the ways that behave really more function like private institutions.
And when you say, and it's worth emphasizing too, so they're nonprofit institutions that receive all these tax breaks, besides really extraordinarily high executive and appropriate executive pay, but they're nonprofit institutions that can also choose which patients they serve and which patients they don't serve, despite being nonprofits.
Yeah, I mean, I think that's also a really important point that I didn't mention is yes. And we see that patients kind of get shunted into the public system. They don't have to see patients, again, outside of the emergency room context who are uninsured or on Medicaid. Wow.
And is it also that if they do see patients who are on Medicaid, for example, are their reimbursement rates, as you mentioned before too, are higher than what they are at public hospitals, or how does that work?
Well, it's more that they have a lower proportion of Medicaid patients, so their payer mix is different. And so for the same set of services to a group of patients, if you have a higher proportion of privately insured patients, your compensation for those services is much higher than if you're skewed towards having a large Medicaid or uninsured population.
I see. I mean, that in itself, says a lot too about the disparities that we've been talking about today. And Sheela, I wondered if you could talk a bit more too about, when we talk about private versus public hospitals as well, one big piece of this too are community health clinics and community-based healthcare work, community health workers. And I thought maybe you could highlight a bit about we know this, but just expand it at a basic level. What is so important about our community-based health clinics and our community health workers? Why is it important to approach healthcare from a community-based standpoint, especially for immigrant communities like ours?
There's a lot of ways to answer this question. But I think that when you're in a community, you're trusted by a community, people are more willing to visit this institution. And so while, so these institutions, which may be smaller and may not have as much backing, they often are more trusted by the community. And so patients are going to seek out the care where they otherwise may feel uncomfortable doing so for a variety of reasons at other institutions. I think that these community-based clinics also are super important because the data is clear. The more that we invest in primary care, the cheaper our healthcare spending will actually be. And so if we are preventing people from getting sicker, we're preventing the city, the government, private insurance companies from spending more money on expensive treatments. And so the key here is really ensuring that people have access to equitable primary care. And these clinics provide that service, and they can prevent people from getting too sick and prevent, illnesses from becoming too serious. And I think that we need these community-based organizations, which often provide, like I mentioned before about these H&Hs, they provide culturally competent, culturally linguistically appropriate care, and make community members feel much more welcomed.
That's a critical, I think, a really important point about the way that community health clinics and healthcare workers are a crucial access point, right, for our healthcare system, or entry point for our healthcare system for so many who otherwise wouldn't be able to access care. I see one last question that I'd open up to both of you too is, should public hospitals have a greater emphasis on public health initiatives? So I suppose also means like education campaigns, education awareness. What is the status of those kinds of initiatives now? And are there more that public hospitals can do in that area as well?
I guess I'll just say that, we have a pretty robust public health system with the Department of Health in New York City, one of the most impressive, I think, across the country. Although, again, we saw the gaps, of course, too, during this pandemic. So I think, there is definitely room for improvement and room for improved partnership, like Chanel had mentioned earlier, with those community-based organizations and community health worker groups. And I think H&H, or Health and Hospitals, has worked at times hand in hand with the Department of Health, and at times has had kind of their own independent outreach initiatives. I would say one aspect of Health and Hospitals that I think has been really helpful in the last year has been the home health care, or the community health services that Health and Hospitals has directly been able to provide. And, kind of speaking to a lot of the things that we've already spoke to, I think trust is one really critical piece that community-based care is an important component of trust between communities and between the healthcare system. And that's something that's been so eroded and so broken down. And so I think that in terms of public health, having those frontline workers who can slowly over time and over long-term relationships develop trust has been such an important tool, and that the home healthcare aspect of Health and Hospitals has played that role to some extent, I think.
Yeah, I completely agree. And I think that New York City, the Department of Health, H&H, actually does a really great job of advertising their services. I think whenever I'm on the train and I see an ad about, from New York City about this is the right way to cover your mouth with your mask, and or advertising for New York City Care, I think that those bits of information that we're disseminating to the public are so crucial. And I think on the other side of that, the public health education that the city conducts is really great and pretty comprehensive. I think that they are quick to translate education materials. They're quick to make them engaging and make sure that they're not overwhelming. I think that, for me as a public health educator, always making sure that materials that I'm providing patients with, community members with, aren't overwhelming. And I think that the city does a really good job of making sure that these materials are meeting communities in a very sensible way.
And I think it's a role that uniquely public hospitals and our public hospital system really takes on compared to private healthcare institutions too, because I do know what you mean about all the advertisements and the announcements, that you see on the trains or, out in the public too. Well, that was really helpful, I think, to go through just a lot of different areas and to give some great information too about our healthcare system too. I want to just highlight to everyone again the links that Chanel put in the chat about ways to apply for vaccines right now, as well as Queens-based centers too. And I think that it's unfortunate there's going to be so many different ways and links to check out, but I do feel like, to Chanel's point, these are really essential and critical ways to keep tabs of all that's happening in terms of openings for appointments and to simplify the process as much as possible. And I know that's a lot of work, Chanel, that you've been doing too, to really make the process more streamlined, especially for our immigrant communities too. So I do want to thank you both so much for coming out tonight too, and explaining to us a bit more about our healthcare system and about the crucial role that safety net and public hospitals play. As I mentioned before too, please make sure to check out our public health platform that we'll be releasing this week as well, as part of this conversation. But clearly, coming out of this pandemic, and there's so many issues, of course, that this pandemic has revealed for everyone. But I do think at the center of it all are issues like health, are issues like housing, and the way they connect with each other too. And I think now it is so clear for so many more two sides of the coin. One, how much our communities of color and local communities were at the center of COVID and the impact that had on public health institutions that were really the front lines of receiving so many vulnerable residents. And two, how much extraordinary work our healthcare workers in these hospitals or in the home health setting did in being on the front lines of this crisis and helping so many that otherwise would not receive care too. And I wanted to really lift that up and mention that point because these need to be the two parts of our focus, I think, coming out of this pandemic when it comes to healthcare too. So with that being said, thank you both so much. Thank you for the information as well. I hope to have you back on for other discussions too. And thank you for all the amazing work that you all do in our communities too that need it so much.
Thank you. Thanks so much.
Thanks. Of course. Yeah, thanks everyone for joining and see you next week as well. And good to see all of you here too. Thank you, everyone. Have a good night.
Bye, everybody.
Bye.